Thank you for joining me for a presentation on logging guidance utilizing resources available through PRR and the Council on Podiatric Medical Education. I am Danae Lowell, the Site Director for Mercy Health Regional Medical Center in Ohio and the COTH Region 4 representative. This presentation is dedicated to assisting program directors and residents with education on logging. The subject matter is divided into two sections presented separately. Part 1 starts with the general overview, logging, as outlined in the CPME guidance documents. Part 2 is a review of the proper logging document available to help understand accurate logging of cases in Podiatry Residency Resource. With some exceptions, every 6 years there is an on-site review that occurs for every residency program. The CPME 320 and 330 documents are used as a guide for the requirements. The review ensures that every program is in compliance with these guidelines. One focus of the review includes resident logging. The majority of programs utilize PRR for logging. The goal is for there to be no errors in the logs, which is possible, but takes a great deal of attention to detail by both residents and the program director. The newest iteration of the CPME 320 and 330 documents took effect July 2023. Depending on the current PGY, some minimum activity volumes, or MAVs, may vary. Standard 6.0 from the CPME 320 document outlines a requirement for all residency programs surrounding logging. Residents are required to maintain web-based logs documenting clinical and didactic experiences related to their residency. Most programs utilize PRR. PRR allows for the categorization and summation of diversity and experiences. Through this presentation, you will become very familiar with MAVs and the full extent of this expectation. Residents and directors should understand that the requirement encompasses a great deal more than just logging the surgical cases. Since this presentation focuses on logging, we will not fully explore the content available on PRR. On the www.cpme.org homepage, there is a tab for residencies and a section on documents and forms. This is where the CPME 320 and 330 documents can be found. It is also required that either the documents themselves or an active link are included in the residency manual. July 1st of 2023 brought the newest CPME 320 document into effect. This pertains to residents who started at that time. Residents already in programs were under the previous CPME 320 document requirements. There were a number of changes, including MAVs and logging, which is what some of the content will focus on here. PRR automatically adjusts the requirements according to the year the resident started. This section highlights content within the CPME 320 document. To save time, we will not review every option within each category. Just understand the following information all comes from the CPME 320. The proper logging document will be reviewed in Part 2 to complete the discussion. From the CPME 320 document, this is the outline of MAVs effective 2023 for new residents. MAVs are minimum activity volumes necessary to meet criteria for graduation. The categories go from 1 to 11. We'll review these categories and I'll offer hints along the way to avoid common errors. Keep in mind that along with MAVs in these categories, a diversity of procedures is required. Make sure you select the best match within these categories to allow for credit of the diversity of the procedures. For an RRA program, there is a minimum of 300 surgical cases and 400 procedures. Multiple procedures can be logged during a single case. A resident can claim first assist when they are actively performing the procedure under supervision of the attending. Residents claim second assist when they are participating in the procedure, but in a more limited capacity under supervision of the attending. First assist counts towards podiatric surgical cases. First and second assist counts toward podiatric procedures. If you add up the category 1 through 5 procedure MAVs, it equals 275, yet the total overall procedure required MAV is 400. The total number of 400 is either reached by doing greater than 400 cases as first assist or logging second assist cases to meet the requirement. Guidance is to log all cases residents participate in. In order to assure resident training experiences adequately reflect an appropriate degree of diversity, a minimum of 33% of codes within each category and subcategory must be represented. This is for first assist procedures. This requirement prevents residents from experiencing limitation of their exposure to cases. An example would be going through 3 years of training and only ever doing an Austin bunionectomy. The diversity requirement ensures the residents are doing multiple procedures on various pathologies. When you log into PRR, this is the dashboard page you will see. It gives an overview of your status in regard to submitted cases, verified cases, and level of achieving the MAVs. PRR is used for more than just logging as indicated in the left-hand drop-down box. If you scroll down on the dashboard, you will see progress towards diversity. This test resident has achieved all MAVs and required diversity as indicated by the green bars. Category 1 encompasses procedures performed on the digits. The MAV for this category is 80. This means one procedure for each toe. They cannot be separated into multiple procedures. For instance, if you amputate a toe, you log a single procedure, amputation of a digit. You cannot log an I&D, management of infection, and plastic procedure in addition to the amputation. If stab tenotomies are performed at the level of the toe, that is a category 6. The important part to note if using the generic other option for logging a case is that you need to support it with details in the description of the procedure to justify why no other option works. Under category 1, you will find these procedures listed. Any procedure done on a toe will fit within the first 12 categories. The final option in blue is rarely ever used. Most are self-explanatory, but I added a couple of examples to give an idea of what can be put in some of the categories. A couple of very common errors include either logging an Aiken osteotomy or hallux amputation as a category 2, which is limited to procedures on the first ray. Those procedure examples belong in category 1 for digits since they do not extend beyond the MPJ. Category 2 encompasses those procedures performed on the first ray. The MAV for this category is 60. This means one procedure for each first ray surgery. If you perform a head procedure and a base procedure, you can only log them as one procedure. You cannot log them as two separate procedures. An Aiken, in addition to a head procedure, can be logged as a digit, category 1, and then a bunion, category 2. The procedures for category 2 are subdivided according to pathology into hallux valgus, hallux limitus, and the other first ray. To meet diversity requirements, there needs to be an assortment in each subcategory. Under category 2 for hallux valgus, you'll find these procedures listed. The last one listed is used for double osteotomies. Just like category 1 for digits, despite the time and amount of work you do, it is one procedure logged to address the deformity. Under category 2 for hallux limitus, you'll find these procedures listed. They are pretty self-explanatory but are chosen when limitus is present. MPJ fusion, implant, and arthroplasty are options under valgus surgery and limitus surgery. Keep the underlying pathology in mind when logging these procedures to ensure you're getting the credit for the diversity. Under Category 2 for other first-ray surgery, you will find these procedures listed, which completes the full array of possibilities covering first-ray pathology. The final option in blue is rarely, if ever, used. The proper logging document to be reviewed in Part 2 will go over do's and don'ts, such as Procedure 233, which is selected for an isolated base fusion. If a met cuneiform fusion is performed along with a lesser met cuneiform fusion as part of fixing a Lisfranc injury, it is logged under Category 4. Category 3 covers soft tissue procedures, generally limited to the forefoot, which is defined as distal to the Lisfranc joint, with a few exceptions reviewed on the next slide. The MAVs for this category is 45, and keep in mind both Category 3 and Category 5 have selections for plastic surgery. Any tendon work in the forefoot is logged here. Rear foot, leg, tendon, ligament procedures are in Category 5. Under Category 3, you will find these procedures listed. If you perform just a sesamoidectomy, this is where it's logged, not under Category 2 for a first-ray procedure if you do a fibular or tibial sesamoid resection. Sesamoidectomies cannot be logged separately if a bunion or partial ray amputation is performed. Procedures performed on the ankle and leg that are logged here include INDs, soft tissue mass excision without reconstructive surgery, tarsal tunnel and compartment syndrome decompression. The procedure other in blue is rarely, if ever, used. However, if a program is heavy in rear foot and additional procedures are needed in Category 3, some of the Category 5 soft tissue cases can be logged here. There are 14 subcategories. When taking into account the diversity requirement, cases from at least 5 categories must be represented. Category 4 covers other osseous procedures of the foot. There are 40 MAVs in this category. Don't get confused about the title of this category being Other. Each category has an Other procedure selection that is rarely used. This is a category in itself. Generally, this is where all the osseous midfoot procedures are logged distal to the tarsal metatarsal joint. The proper logging document assists in understanding how and if procedures can be unbundled or need to be logged together. An example is a partial ray amputation, which is logged in Category 4 as a single procedure, or if multiple ray resections are performed, it is logged as a TMA. Keep in mind that amputation of adjoining metatarsals or rays is logged as one procedure. However, non-adjoining metatarsal or ray amputations can be logged separately. Under Category 4, you will find these procedures listed. They encompass procedures on the lesser metatarsals, including tarsal metatarsals. Procedures on locations other than distal to the TMT region that are logged here include ostectomies, bone harvesting, and Haglunds. As mentioned previously, the other procedure option in blue is rarely, if ever, used. However, if a program is heavy in rear foot and additional procedures are needed in Category 4, some of the Category 5 osseous cases can be logged here. Note the selection for Haglunds. Panmetatarsal head resection would be listed here as a single procedure. 4.13 is where first ray met base fusion is included in the ORIF of Lisfranc injuries. Category 5 encompasses those procedures performed on the midfoot and rear foot proximal to the TMT. The MAVs for this category is 50 for RRA programs. The general rule is the work you perform to correct one pathology equals one procedure logged, and keep in mind that logging MAVs in PRR does not follow how a provider might bill for a procedure. Even if you could bill multiple procedures for a case, logging is different. With exception, an ankle is an ankle. Category 5 is further subdivided into elective soft tissue, elective osseous, non-elective soft tissue, and non-elective osseous procedures. To ensure diversity is met, make sure the appropriate selections are made according to the pathology. Under Category 5 for elective soft tissue, you'll find these procedures listed. They encompass correction of chronic type injuries to soft tissues, tendons, and ligaments. The last one listed in blue is rarely if ever used. The proper locking document very specifically outlines which procedures can be selected individually versus those which are required to be bundled together. For instance, you can't log 512 and 514 at the same time. You can, however, log 515, which is a ligament, with 512 or 516, which are tendon work. Under Category 5 for elective osseous, you'll find these procedures listed. They include, but are not limited to, osseous correction of chronic type injuries and includes arthroscopy, arthrodesis, coalitions, complex deformity correction, and implants. The last one listed in blue is rarely if ever used. Multiple procedures count as one procedure. However, 525 can be claimed in conjunction with 524, 526, 527, and 529 when an osteotomy was done to correct RRA deformity. An example is if separate osteotomies are performed to correct a deformity, such as an Evans and Cotton or Evans and medial sliding calcaneal osteotomy. Under Category 5 for non-elective soft tissue, you'll find these procedures listed. They encompass soft tissue correction of more acute type injuries, including tendon, ligament, and more advanced nerve or soft tissue reconstructive procedures. You can log only one procedure per foot of ankle, even if multiple ligaments are repaired. 536 cannot be logged in conjunction with an open repair of fracture or acute ligament repair, and the one listed in blue is hardly if ever used. Under Category 5 for non-elective osseous, you'll find these procedures listed. They encompass osseous correction of acute injuries such as pediatric versus adult fractures, bone tumors, infection management, and proximal amputations. One procedure per foot. Soft tissue repair is included. The one other option listed in blue is rarely, if ever, used. Part 2 of this subject matter reviews the proper logging document, which goes into greater detail for each of these categories. I presented a few examples along the way to give you an idea of how the CPME 320 and proper logging document work together to lessen confusion. Category 6 encompasses those procedures performed outside the categories 1 through 5. This MAV requirement is new for the July 1, 2023 academic year and is 100. They encompass various lower extremity procedures that may be performed in the outpatient clinic, inpatient, or operating room arenas. Under Category 6 for other podiatric procedures, you'll find these selections listed. This is where stab tenotomies, orthotics, injections, closed reductions, and both hardware removal and application of external fixators are logged. Also note that simple laceration repairs, I&Ds, foreign body removals performed outside the OR are logged here. If you do a bedside I&D, it is logged under Category 6. Bedside procedures are not logged within Category 1 through 5. All percutaneous procedures are logged here with the exception of a stab TAL for Achilles, which is logged under 513, tendon lengthening involving the midfoot, rear foot, ankle, or leg. A common error is logging application of an X-Fix as Category 5. All X-Fix applications are logged here under Category 6. Category 7 is for biomechanical cases, and the explanation above assists with determining the extent of the exam and circumstances appropriate for logging. There are 50 MAVs in this category. A biomechanical exam that fulfills the requirement for the MAV starts with a chief complaint and progresses through a comprehensive biomechanical exam and gait analysis related to that complaint, an assessment consistent with the complaint, and conservative treatment directly related to the biomechanical pathology identified. A patient with an ingrown nail who is treated with a partial avulsion and reappointed in a week for follow-up is not a biomechanical because they were also noted to have pes planus. However, if that patient presents with painful hallux deformity and subsequent medial ingrown nail, has a gait analysis and biomechanical exam performed revealing pes planus, HAV, and resulting roll-off of the medial aspect of the hallux, and is diagnosed with such, and prescribed CFOs for treatment, all of that in addition to the ingrown nail and partial avulsion, that would suffice for a biomechanical exam as long as it is all documented. Under Category 7 for biomechanicals, you'll find the above selection. Again, the complaint, exam, assessment, and treatment is consistent throughout. Biomechanicals can be obtained as part of the care of pre-surgical patients, but still needs to address the above components in the care and documentation of the patient. It is understood that biomechanical considerations are made when working up patients and that surgical procedures can address biomechanical pathology. However, performing surgery does not equate to a biomechanical case that fulfills the MAVs for Category 7. Biomechanical exams are performed in the pre-surgical and non-operative settings. Surgical setting does not mean on the gurney in the pre-op area outside the OR. Surgical setting is perhaps a pre-op clinic where the complaint and conservative treatment failures, gait exam, biomechanical findings, surgery planning, and post-op CFOs are documented. Keep in mind, only one biomechanical can be listed per visit per patient. They can't be logged separately for right-left. The focus of this category is biomechanical etiology and conservative treatments rather than surgical treatment. Diversity in logging these cases is required. Category 8 encompasses history and physicals and is divided into either comprehensive or focused exams. There are 50 MAVs for this category. Only comprehensive H&Ps count towards the MAV, and they may be performed in the outpatient clinic, inpatient, or pre-op setting. Under Category 8 for H&P examinations, you'll find the above selections. Comprehensive history and physical exams count towards the MAV. This includes a full medical history as well as surgical, family, and social history. Documentation of medications, allergies, a review of systems is completed. Documenting vital signs and a physical exam head to toe is expected. The problem-focused history and physical exam does not count towards MAVs, but is useful for logging system-specific vascular, dermatologic, neurologic, or musculoskeletal patient encounters during non-podiatric rotations. Category 9 encompasses surgical specialties other than lower extremity. There are no MAVs for this category. However, there are requirements for non-podiatric surgical rotations and for residents to log their experiences during all rotations. The expectation is that when residents are on these rotations, cases, experience are being logged. Keep in mind that any procedure performed within the scope of podiatry can be logged within Category 1 through 5, regardless of the service under which it was performed. For example, if a resident participates in a plastic surgery lower extremity orthoplastic procedure and performs as first or second assist, it can be logged in Category 5. BKAs and AKAs are not Category 5. They are logged as Category 9 under vascular, general, or ortho, depending on the rotation. Category 10 encompasses medicine and medicine subspecialties. There are no MAVs for this category. This busy slide represents every other possible non-podiatric rotation. Again, the requirements for logging during non-podiatric experiences continues for any rotation. The expectation is that when residents are on these rotations, experiences are being logged. These are non-podiatric in nature. Pediatric cases count towards MAVs only when they are podopediatric in nature and are logged under categories 1 through 8. Category 11 encompasses lower extremity wound care. There are 50 MAVs for this category. The options for logging are here. 11.1 would typically encompass those less complicated clinic, ER, or bedside sharp excisional wound debridements. Category 6 would be used for more complex INDs. If you're placing a vac-assisted closure device, tissue product, or applying an intricate lower extremity bandage, 11.2 is used. Hyperbaric oxygen therapy experiences are logged under 11.3. Category 13 encompasses those other clinical experiences. There are no MAVs for this category. The options for logging are here. If your residency includes time away from mission trips within or outside the U.S., use this category to document your experiences. The trauma category encompasses experiences in managing acute trauma defined as within 6 weeks of initial injury. There are 50 MAVs for this category. When you log experiences such as H&Ps or surgeries, the option for selecting trauma is present. The advice is to log as many traumas as you are exposed to. However, at least 25 must be related to the lower extremity. One resident may count both the surgery and the trauma if they perform as first assist. That can be divided up between two residents. If one performs as first assist and takes a surgery, the other one performs as second assist and claims the trauma. The podopediatric category encompasses experiences evaluating and managing care for patients who are less than 18 years of age. There are 25 MAVs for this category. When you log experiences such as lower extremity H&Ps, biomechanicals, surgeries, regardless of service or rotation, the patient's age is required and added to the MAVs. When logging cases and more than one resident or fellow is involved, only one trainee can log first assist on any one procedure. However, multiple residents can log as second assist. It's very important to clearly define activities when both fellows and residents are present in a single institution so that case or procedure volume or diversity is not jeopardized for the resident. If multiple procedures are performed on a single patient, first assist can only be claimed once per procedure. Those procedures cannot be fragmented or unbundled to allow multiple first assist logging. If a podiatry resident is the only podiatrist present during a case where all the other trainees are non-DPMs, they cannot automatically claim first assist. The role of first assist logging of that procedure goes to the trainee performing the work under the direct supervision of an attending. Otherwise, second assist is claimed. Now that you're aware of some of the logging basics, you may wonder how your logging figures into the overall process of getting MAV credit for cases. It is extremely important to log cases within a short period of time after completing them. There are requirements for timely logging verification that the program directors have to meet. Program directors may contact residents about logging errors noted and request edits. Once the logs are accurate and the CLAD report is clear, the program director verifies the case logged. Upon verification, the case is then official in the record and will count towards MAVs and diversity where indicated. Verified logs can be unverified and edited if necessary, but this can only be done by the program director. The CLAD report is in place to assist with identifying errors in logs. If an error is generated when a case is logged, the CLAD report will give guidance on what the potential issue may be. Some errors do not allow for submission of the log. Other errors require clearance by the program director prior to verifying. Any changes that need to be made after the log is verified by the program director requires them to unverify the log and re-verify when changes have been completed. Program directors are not able to graduate residents out of PRR until all MAVs and diversity is met, in addition to an error-free CLAD report period. The CLAD report can be found in the drop-down box on the left-hand side of the dashboard on PRR. The test resident here has an error because they used the other category for a soft tissue procedure. This example of an error will be discussed shortly. Cases with CLAD errors are posted on the Program Director dashboard. When the CLAD report tab is open, it looks similar to the resident but has options for unverifying, clearing, and notifying the resident about case errors. There are some important specific logging errors to explain. Not all are picked up by the CLAD report, so it is imperative that residents and directors educate themselves on proper logging and foster an environment of continued education and reinforcement of the requirements. If a case is logged in the wrong category, such as an ACHIN, which is a Category 1, into a Category 2 instead for first raise, that is called miscategorization. If a single case is deconstructed into multiple parts that goes against proper logging guidance, such as doing a partial fifth ray, which is Category 4, other osseous, into a toe amputation Category 1, a metatarsal resection Category 4, I&D Category 3, and plastic procedure for closure Category 3, you fragmented or unbundled and created 4 procedures instead of the correct single procedure. Duplication of a case occurs if it is logged more than once. Sharing first assist on a single procedure when multiple trainees are present is also prohibited. Both examples of fragmentation and duplication or sharing cases falsely elevates the logs and are not allowed. These examples of logging errors are easily discoverable and preventable by attention to detail by residents, fellows, and directors. Presentations such as this are offered to educate residents and program teams on logging in the hopes that it will reduce occurrences of potential areas of noncompliance during on-site reviews. We're going to review just a couple examples. Here are some common examples of miscategorizations. An ACHIN is performed on the proximal phalanx, therefore it is in Category 1 for digits. If a procedure is performed on the first metatarsal, the Category 1 ACHIN can be logged in addition to the Category 2 bunion. A disarticulated hallux is Category 1, not Category 2 because the procedure did not involve the first metatarsal. If a partial first ray is performed, then a single Category 2 can be logged. An isolated sesamoidectomy is logged as Category 3, not Category 2 for first rays. If it is done as part of a bunion correction or partial first ray amputation, it cannot be logged separately at all. Bedside debridement counts towards Category 6. Only those procedures performed in the OR can be counted towards Categories 1 through 5. And again, applying an external fixator, even with as much work as it requires, counts as Category 6 rather than Category 5. Here are some examples of fragmentation frequently encountered. Bunion procedures that have been separated into multiple procedures. Midfoot and rear foot procedures that count as a single number but have been logged independently for each joint or bone encountered or each ligament repaired. They are all inclusive for a single procedure. When the statement an ankle is used, that is what is referring to. A single trauma or deformity is dressed through various surgical means but counts as one procedure. While billing a case may allow for fragmentation, MAVs were not designed along the lines of billing criteria. In the notes section of logging a new procedure, residents are expected to document descriptive information regarding the case. The info here supports the category. Do not copy and paste lengthy reports detailing every aspect of the case in minute detail, but also do not just document a bunion was fixed or leave it blank. This is where the full extent of training and experiences are documented. A bunion procedure note can state Austin bunionectomy with absorbable pin fixation or Mitchell osteotomy with crossed K wires. Instead of just logging an ORIF of an ankle, residents should be documenting it may have been a trimalleolar fracture with specific industry plate fixation of fibula, with syndesmotic screw fixation of the medial malleolus, anterior approach with screw fixation of posterior malleolus fracture, deltoid ligament repair, etc. This test patient log in PRR shows where the notes are made for the procedure. Pertinent unique details for the procedure are entered here. The CLAD report will pick up on errors including duplication if two procedures such as an IND are logged twice for the same case. Information in the procedure note would reveal that procedure 1 is an IND on the plantar foot in addition to procedure 2, which involves the lateral leg. The director will be able to clear the case from CLAD report because of the detail provided in the procedure note. Thank you. I hope you found the information within this presentation helpful. I referenced the CPME proper logging document throughout this presentation and cannot stress enough how useful it is. Part 2 will review the proper logging guidance document in greater detail.